think, the hope with this video is that every person who has someone South Asian in their life or is South Asian themselves can be having that conversation with a really excellent, knowledgeable person, you, who both is South Asian, is a cardiologist. We'll let you talk through a little bit your experience on the topic. And then finally, has a really amazing success story within your own family that I hope we can get to talk about sometime today.
Yeah, no, I'm super excited. So I'll let you take the lead and let's get on let's get going.
Awesome. Cool. Well, I mean, I think the first thing just to level set for people is, is it really that different? Like, are South Asians at a higher risk for heart disease, and what is it specifically that they're higher risk for? And, how much worse is it?
Yes to everything, first of all. So yeah, across the board. So yeah, no, I mean, South Asians definitely have a higher risk of, cardiovascular disease. But I mean, this is a hard topic to approach because cardiovascular disease is a huge spectrum of diseases. When we talk about heart disease, usually we're talking about coronary artery disease, which to people, when we talk about it, is blockages in the heart arteries. And those don't always occur in isolation. They also occur with the cardiometabolic syndrome that South Asians are definitely more susceptible to. I think that if you look at studies show that we have almost a 2x higher rate of diabetes compared to age-controlled matches across almost every ethnicity and every population. So they've looked at South Asians in the UK, almost 2x the rate of diabetes. South Asians in the US, almost 2x the rate of diabetes. And it's a weird mix, right? Because we also have it in India, in Pakistan, in Bangladesh.
Right.
So it's both. Diabetes is concurrently a disease of affluence and of poverty. And we've gotten the worst of both sides of that coin because of some of the habits that we brought with us and some of the less than healthy habits we may have adopted. Metabolic disease.
I want to kind of round out what we know about why our risk is higher.
I mean, I think there are multiple studies. We all know BMI is a flawed metric. It's just the best that's been there, but it's used based on European age norms. There are suggestions by the WHO that the cutoff for obesity in Asians, and they include East Asians and South Asians, should be 25 or 27. In fact, for obesity studies related to GLP-1s like the Ozempics of the world, in Asia, they actually use 27 as a cutoff instead of 30. So the bone size, the mass is different. How the tissue is distributed is different. By that, I mean, South Asians are known to have more quote unquote central adiposity. And what that means is kind of little stomach. There's also just the physical anatomical changes. We factually have smaller coronary arteries than Europeans of the same age. Look at the coronary artery. It's a tube, right? It's a circle. And the way I explain this to my patients sometimes is it's kind of like looking at a pizza. When you order a 12-inch pizza from Domino's versus the upsell on a large pizza, you're actually getting 40% more area. And that's because of geometry, right? And because it squares with the radius. So if you have an artery that averages 2.6 millimeters in South Asians and it averages 3 millimeters in Western European or non-Hispanic white populations, then you're talking about an artery that goes from this big to this big. You just have less room to deal with overall.
Yeah.
And that's why study after study shows that we have more metabolic disease. We have more coronary disease. We have more multivessel coronary disease. Your heart is a muscle and it needs oxygen to pump.
To kind of like the testing realm and sort of how people can decide when that inflection point is for them.
Yeah. So, I mean, with the advanced lipid panels, there are a ton out there. So I think that knowing your lipid risk, more importantly, knowing your hemoglobin A1C really drives a lot of what's going on. There's also high sensitivity CRP. So when you think about how you get a blockage in your heart arteries, you have the cholesterol, right? Which is your LDL. That's the bad cholesterol that's always there. When you have inflammation, either in the form of higher glucose, higher blood sugar, or in the form of high CRPs, that's what activates this molecule and makes it sticky. And when it becomes sticky, it sticks to the walls of the arteries and it starts to develop plaque. Stress can be a significant driver. And stress leads to inflammation. In this context, again, some South Asian researchers are ahead of the curve. There are literally studies that show that yoga can lower your blood pressure, actually reduces heart failure readmissions. Then there are imaging tests that can look and give you surrogates of what's going on. So the calcium score is a test that has a lot of evidence behind it, and a lot of people use it. It's a CT scan, a very low dose, CT scan that you can go through. And it looks for calcium because that's what you can see on a CT scan. Calcium is a surrogate for plaque, and it's usually long developed plaque. So we use that as kind of a screening test. So CT angiograms out there. So that's the CT test that I was just talking about, the imaging test. They inject a dye that goes through your arteries.
Take some time to hear about kind of, what happened to your mom, what she realized she wanted to do, what you encouraged her to check out.
Cool. Yeah, so my mom, this happened actually probably about 6 or 7 years ago. So much like a lot of South Asian uncles and aunties out there, she's had diabetes. She had high blood pressure. She got IgA nephropathy, which is an autoimmune disorder which attacks the kidneys. Wow. We got her on 2 transplant lists for kidney transplant, at 2 different places across the country. We had her seen by specialists everywhere. Her blood pressure was getting controlled, but her numbers were not great. They just weren't getting better. And what happened with her hemoglobin A1C was still around 9, but got her the Dexcom, and she was tracking the meals by herself. And her glucose got a little bit better, but it didn't make significant changes. So what ended up happening is that I made sure that she shared her information with me, and I would track it with her. So I would see when she had a meal, if her glucose went to 220 or 250, and I could say, "Hey, Mom, what did you have?" And then after about, I want to say like 2 weeks, it finally, of those reinforcement things saying what happened here, what happened there, then it clicked through, because all I did was close the feedback loop, right? It wasn't a 6-month visit to a doctor. All I did was close the feedback loop so she could actually decide what caused her to have that. So she made the most desi awesome changes ever. Just importantly, her kidney function got better, right? Yeah. And she's off the transplant list. It just took that little bit of understanding and following. So she wears the Dexcom. Now, that's not to say she won't go to a wedding and somebody has mithai and she'll eat the mithai. They're going to make decisions the way they want to make decisions. All we can do is arm them with the information. And I believe everybody should enjoy themselves in moderation. That's a lot of what we kind of hinted at. What we're trying to build is trying to arm.
Tell us a little bit about what you're working on, because I think it's really cool, and I think maybe we can have like a follow-up video in a little bit once I'll try to CGM and you'll tell us how things are going with your test sites, and we can kind of pick up where we left off.
Yeah, no, that sounds great. I mean, we're building a platform to bridge the gap between patients and providers, so that way you're not just stuck with those 15-minute visits every 6 months where you don't have time to make eye contact. So we connect with all sorts of sensors and consumer level devices, and we can transmit that data to the physicians, and then really close that feedback loop back to the patients, right?